Great. So I'm going to be talking on massive bipolar bone loss post-anatomic shoulder replacements. So the last time I was actually in India, I was in Ranthambore photographing tigers, so it's great to be back here. So this is a case of a 67-year-old female who presented 8 years post-anatomic shoulder replacement, and she came in complaining of progressively worsening pain. Pain was present at rest and during activities. She had no problems in the perioperative period when she had her anatomic, and she was also complaining of a restricted range of motion. Examination, the patient had a scar which was well healed from the previous surgery. She had weakness of subscap and supraspinatus, normal strength in infraspinatus. There was a restricted range of motion with forward flexion 100 degrees, external rotation 20. She could internally rotate to the buttock, and she was neurovascularly intact. So we proceeded to do a standard set of x-rays, and this showed massive osteolysis on the glenoid with loosening of the glenoid component. The humeral stem had a pedestal, and there was also loss of bone extending into the metaphyseal, almost into the diaphyseal region. So just for your information, this was a DePuy prosthesis, and the polyethylene at the time was Hirner polyethylene, which in the knee and other joints resulted in catastrophic polyethylene wear, and this polyethylene was later withdrawn from the market, and we've had quite a few of these patients who had shoulder replacements who've had this massive catastrophic poly wear. So we did an ultrasound scan which showed that the subscapularis was torn, supra and infra were intact. Did a CT scan which was okay, wasn't that helpful because of the metal. I'll just run through it quickly. It showed massive uncontained glenoid defect with central wear, and there was also just a thin rim of bone left around the actual proximal humerus. So I won't go through that one. So this is the proximal humerus, which just showed a thin rim of bone around the actual proximal humerus and quite significant bone loss medially. So there was a concern that this patient may be infected, so for what it was worth, we did a C-reactive protein ESR and white cell count, which came back normal. We did an aspirate and grew this for 3 weeks where there was no growth, and we did synovasure, which also came back as negative. Doesn't exclude infection, but we weren't that concerned that this was infected. And then we proceeded to produce a 3D scapula just to get a better idea of what the scapular defect looked like. It's quite difficult to look at this, but if you look, there's bony erosion medial to the base of the coracoid. There's a massive uncontained anterior defect, large central defect. So overall, this patient's got less than 10 millimeters of the vault left as well for potential fixation. So I'll go to the first ARS question here. I'm not sure if I've done this correctly, but the first question, so just would anyone in the audience revise this to an anatomic, or would your preference be a reverse? Okay, good. That's great. So we can move on quite quickly. So I think generally we're all probably going to go, well, majority of us are going to go for reverse. Okay, so this question was really, I put this question in there for the surgeons that felt they were going to revise this to an anatomic, so I'm actually going to dispense with this and just move on. So this patient needs a revision. I think everyone, if they're doing a reverse, we're going to revise to both sides. So again, we can probably dispense with this question as well. Oh, okay. So some people are only going to revise the glenoid and leave the humeral component. So this is not a modular humeral component. So if you're going to revise it to reverse, you can't actually leave the humeral component. So I'm just going to move on to this classification. So this is a classification. There are lots of different classifications for massive bone loss in the glenoid. This is Sebai and Gupta's classification, which classifies these defects according to whether they've got massive central loss and whether they've got peripheral loss and then what quadrant it occurs in. So this patient has actually got an C4, E4 glenoid, which means they've got massive destructive central lesion with more than 60% of their bone loss is missing in the glenoid. Okay, so this now brings me to a more relevant question here. So if you're going to revise the glenoid, and if you're going to do a bone graft on the glenoid, are you going to do this as a 1-stage or a 2-stage? Okay, so you're going to do a 1 or a 2 stage?
It's always easier to say 2 stage because you hope that the patient may not turn back to you.
Okay, so 60% say 1 stage, 40% of you say 2 stage. Can I just see a show of hands in the audience? How many of you in the audience have actually operated on this type of glenoid defect? Okay, so the reason why I put up the classification and show that it was an E4, C4, E4 is that that actually came from Gupta and Seebauer's research, and they're very big bone grafters. They love bone grafting everything. I'm a little bit different. I prefer to use metal. And they actually showed that their results in that type of glenoid, that's an C4, has bad results as a one stage because you don't get stable fixation of the bone. So there's too much micromotion on the bone, and they actually had a much higher failure rate. So they have suggested that if you are going to bone graft, you should probably do those as a 2-stage procedure. Okay, so this is really just asking the audience, if you are going to revise this, are you going to use bone or are you going to use metal? Okay, so it's very different to where I come from. We've got metal available. I know you may not have metal available, so bone graft. So I think if you are doing bone graft, you then need to make this a structural allograft. You have to be able to fix it to the native glenoid. If you are going to do this as a 1-stage, you need to have good initial fixation. But as I said, with this particular type of defect, you don't actually have enough initial fixation. There's too much micromotion. So you should probably be considering doing this as a 2-stage procedure. So the question then is, if you are doing this as a 2-stage procedure, what are you going to do for the humeral side? So we'll come back to that a little bit later. So if you're using metal, there are 2 primary choices here. You can use an augmented, well, you could think about using an augmented base plate. And these come in a number of different varieties, so you can have these half augments. And for that, you need to have a 50% platform or native bone in contact with the augment, and then you can rotate the augment into the defect. So really, this case, it wouldn't work. You can't use this type of base plate, or you can't use a larger augmented base plate. You'd have to do bone graft first, and then use an augment. So you might as well just do bone graft and use a normal base plate. Okay, so when you have complex bone loss, the fixation points are really the difficult point, and the majority of the time when most of us are fixating a base plate, we use the glenoid centerline, but Frankel speaks about using the scapular centerline, and this just changes the version, but there's very good bone fixation. So this particular patient, as I said, doesn't have a platform for an augment. I do lots of augments. And when I started doing augments, a lot of these massive bone defects I could actually treat with augments because I just needed a 50% platform. I could ignore the rest of the glenoid and just rotate the biggest augment into the defect and get good fixation. So in fact, I didn't have to bone graft a lot of the patients. I could deal with massive bone loss, but this case is a little bit different. So someone mentioned earlier the 3 best fixation points. You need to look at the scapula as a tripod. 3 best fixation points, and they're always there, are the coracoid, and the medial border of the scapula and the scapular pillar, and those fixation points are always there. So whether you're doing bone graft or using metal, you can always find these points, and they are consistently the strongest fixation points of the scapula. So I know, unfortunately, I know you probably don't have this available, so we do have this available in New Zealand, and I work in an institute that if we put in motivation, we can get these custom implants made, which are really a little bit of a game changer for this, because you can actually plan your fixation. So you build that 3-dimensional model that I told you about, and you can then actually design a custom implant, and you can build up like little saddles, or you can put on additional bits to the metal like this, which I always do this with these, and they go onto the coracoid, and you can see here, you can aim for tripod fixation, going to the coracoid, the spine of the scapula, and the medial border of the scapula. And with this, you can always do this as a 1-stage procedure because you get very good initial fixation. You get less than 150 millimeters of motion, and it does allow for definitive humeral treatment.
Just a question. Regarding the imaging workup, I suppose you did the CT scan that you showed. And I also suppose this is the VRS system,
Yeah.
correct? Did you have any issues with the protocol you used? Was it accepted with no problems by the company to
So
give you the PSI
we've got
system?
two options now. So we can use either the company reconstruction of the VRS, but we've got a company in New Zealand that will do the metal extraction and build the scapula for us, which we tend to use more because it's a little bit close to home. So personally, I haven't had an issue with it, but I can see how you could have an issue, especially if they can't extract the metal where effectively, if they've got metal in there previously.
Yeah, absolutely, because even if you decide to accept those images,
Yeah.
images to make the proper evaluation and decision, the engineers, that will use those images to perform, to have the PSI guide available and
Yeah.
the custom-made implant available, will probably not accept it.
Yeah, so I design the custom implant myself now. So the engineers will often come back with a custom design which I'm not happy with, and I'll always redesign it because I want something to go up onto the coracoid, which so there's a lot of backwards and forwards. This particular defect is so big that a PSI guide, and I'll show you what it looked like. Okay, so coming back to the humerus now, so this is a classification. This is Pascal Boileau's classification of humeral defects. There are lots of other ones, like there's the Pharos classification. This is quite easy because it's just A, B, C, and D. So this patient has it's a type B. Well, it's actually a type C, but the deltoid was actually intact in this patient. So we come to the next question here. So if you're revising the humerus, how are you going to revise it? Are you going to be using a bone graft like an APC, or are you going to be using a tumor prosthesis or mega prosthesis for this? Or I haven't put you something else, but you guys might have something else. The TP is a mega prosthesis. Okay, so again, 50-50, I think that's good. I'm quite happy with that. I think both choices have got benefits, and both choices are very good. But let's just come back to the humerus now. So the majority of the people in the audience said here you're going to do bone graft. I think it probably needs to have a two-stage. So in the first stage, what are you then going to do on the humeral side? Because you're either going to have to, you probably can't really do a hemiarthroplasty because it's not going to be stable. And a hemiarthroplasty in that type of defect will actually result in a lot of bone resorption when you come back. So you've got to, what are you then going to do on the humeral side? So again, I think on the humeral side, if you were going to do a two-stage, you can still prepare everything. So you could still prepare everything, but then you've got to be using a modular reverse type of system that you can just put in a tray and leave it and not do a hemiarthroplasty, but leave it more as a humeral girdle stone and then come back and do it once there's been integration. And that's primarily because there's this C4, E4 type of bone defect. Okay, so APCs, it is a biologic solution. You have to be able to get bone graft. You can either use the proximal humerus or the proximal femur. You get better deltoid wrapping theoretically with these, and it is a theoretical advantage. I'm not sure whether it's that true, whether the bone, the deltoid wrapping is better than if you're using a lateralized humeral component. You can reattach the tendons, but again, these have to unite, so you've got two elements that have to unite. And if you use a type of prosthesis that's modular, you can put on a reverse tray or hemi or do a girdle stone. Segmental, this is a segmental reconstruction system. This is it's very easy to use. It does have little metal attachments that you can attach tendons to. It's modular, so you can reconstruct various lengths. You can do a hemi or a reverse, and in fact, you can actually do a total humerus and attach an elbow to it as well. So what did I do? As I said, fortunately, well, I'm lucky. I've got access to custom implants. I was able to do a custom implant, and I did an APC in this particular patient. So this is the custom implant that I designed, just with that little extension that goes onto the coracoid. With these custom implants, you can actually predetermine your screw trajectory, Now, I just have to tell you that actually the exact same system is available for bone grafting as well. So if you do bone grafting, there is a PSI system that's available for bone grafting that you can design it, have a PSI guide that actually directs your screws into the same position, recreates the joint line and your center of rotation. So that's what I did. This is what the actual custom implant would look like when it was implanted. At the time of surgery, I was still not convinced about infection, so we did multiple specimens. I always take 5 specimens. We do MCNS, frozen sections, look at the PMN count. One of the things that you have to remember with these APCs is it's critical, so I always do an x-ray of the other side to look at the length, and I measure the length of the other humerus and then recreate the bone or the APC based on the length of the other side, so fill in the defect. I always do a step cut, so I'll prepare the actual humerus first. I then cement the actual proximal portion into it, and then I'll cement the bottom into it, and then I use either cerclage wire or tape for fixation. It's actually a very stable construct, so this is what it looked like in the post-operative period. She's functioning very well. This was done a long time ago. She's pain-free at 7 years. She has forward flexion to 130, and she's got external rotation to 40. But I just want to show you something. So I re-x-rayed this, and basically the bone has completely resorbed, and now she's just got cement sitting around the implant. So I've actually stopped using APCs, and I just use this type of tumor prosthesis now. It's easier to use, the complication rate is lower, I don't have to worry about infection, and these APCs are fairly expensive. And just coming to the literature on this, so there's not a lot of literature on these type of reconstructions. So there are case reports on APC, there are case reports on these tumor prostheses, and most of it actually comes from tumor literature. And then there's a lot of controversy about whether you should do bone graft or metal. I think there are fairly good results in bone graft. It's a technically difficult procedure, it takes a long time, but I think you can get ingrowth into the bone. The complication rate is up to about 16%, whereas the complication rate of metal is a lot less than that, and the infection rates are a little bit lower, but there are potential problems with metal as well. Thank you.
That's an excellent case, Mark. Just one question. How is this custom-made granite vault system is different from the on-the-shelf VRS system in Zimmer Biomet?
So the biggest wedge from Zimmer Biomet, for example, is a 30 degree. So there's a 10, 20, and 30 degree half wedge. You need to have, as I was saying earlier, you have to have a platform. So you have to be able to create a 50% platform for the flat part of that augment, and then you've got to be able to rotate that augment. In this case, it would have been a 30 degree, but this was so big, the defect, that even with a 30 degree, I wouldn't have anything to fix it onto. So you'd have to bone graft that first and then do it. And it's okay. I mean, you can use it's that 50% rule that was being spoken about earlier. So if I get 50% bone-on-bone contact with the augment, then I'm happy to bone graft behind that. And the results will be good, provided you can get stable fixation with the screws. So, yep. So this particular case was one of the first cases that was with the VRS when they came out, and I thought, wow, this is, I'm going to be using these forever, and with all these big bone defects and all this high limb wear and everything. But in fact, the augments came out about 2 years later, and I almost never ever have to do these custom implants because I can use an augment and actually just rotate it into the defect now for these big bony defects. And the other thing with custom implants, they're very expensive.
Yep.
Whereas the augments are on the shelf, and you can just and then other companies have got different augments. You can have a full augment. Or some companies have got an oblong tray. So yeah, you can use an augment with bone graft definitely, if you need to.
Thank you.